Dr. Eric Lieberman, who is a cardiologist, and we're going to interview with him so that we know more about cardiology, because so many of you go to your internist and all of a sudden there's a heart murmur, there's something, and they say, oh, well, you have to go see a cardiologist. And we're going to talk to Dr. Lieberman and say, all right, well, what does that all mean? So thanks for coming on the show, Dr. Lieberman.
Thank you for having me. I appreciate it.
Right. Well, it's always a little scary. I mean, it's funny how we live every day, our heart's beating, we don't even think about it, right? Just like we breathe, we don't think about it until you go to an internist or your primary health care physician, and he says, oh, got something going there. And then he says, I'm going to recommend you go see this cardiologist. Then what happens, Dr. Lieberman?
Well, it's going to depend in large part on what's going on in terms of symptoms or whether or not the internist sees something on an EKG or hears something when they examine you. So let's take it sort of one step at a time. In terms of symptoms, obviously, if an internist or even the patient themselves notices symptoms that are worrisome for heart disease, such as a discomfort in the chest, in the neck, in the arms, something that may represent a problem with blood supply to the heart muscle, then that's going to require further investigation. It may require initiation of medications. It may require us doing a stress test to get a better idea of what's going on with the blood supply to the heart muscle. And then based upon that, make recommendations about how best to proceed in terms of evaluating the blockages, whether they're best treated with medications, whether we need to contemplate something more aggressive, such as an angiogram to look at the blockages and then do something about them, such as with a stent, or in more significant situations, bypass surgery.
Well, I hope, and I know from talking with you, and I know that you are a younger cardiologist, correct? Not one of the...
I don't know what younger is anymore. Some people call me middle-aged, but I'm happy to be called younger right now.
Okay, we'll call you younger. But the most important thing is that just as when we know about physicians who are very good, but when they tell someone something serious, you have cancer, you have heart disease, and they said, and we're going to, help you do it, and then he kind of walks out of the room. It is so mind-boggling for someone to have this happen, and you're just sitting there, and whether you hold their hand or whether you go through everything, it's almost like medication.
Yeah, developing the rapport between the patient and the physician is extremely important, because it's going to become a collaborative effort moving forward in terms of managing the problem. If somebody does have heart disease, it's going to be something we are, to some extent, going to be dealing with for the rest of their lives. So you want to make sure you have a relationship where you feel like there's a team approaching the problem to deal with the issue that you have to deal with today, but also, probably even more importantly, to preventing problems down the road. And that's why I think one of the most important things in cardiology is not only dealing with the here and now, but what can we do to prevent cardiovascular disease in the future. First of all, in patients who may have symptoms, and equally, if not more important, in patients who don't have symptoms. It's extremely important for everyone out there to recognize those things that are risk factors for heart disease, get in, see somebody, and get those risk factors addressed, and then develop a team effort so you can figure out what to do.
That's excellent advice. So is high blood pressure an indication of something to do with the heart?
It is. So the things we really worry about in terms of risk factors for the development of heart disease is, one is high blood pressure, as you mentioned, and high blood pressure is infinitely treatable these days with far better medications than we had as recently as 10 to 15 years ago. The medications are better tolerated. We can control blood pressure to a much greater degree, and as a result of that, we can reduce the risk of cardiovascular disease. Other risk factors are diabetes, and again, our ability to control sugar and control diabetes is also dramatically improved with the current pharmacologic treatments that we have. Smoking is a major issue, and one of the things that I'll take a lot of time and sit and talk with my patients about is what can we do to eliminate smoking. And by eliminating smoking, within a very short period of time, you can dramatically lower somebody's risk for heart disease. We also worry about cholesterol, and again, with the newer agents that are available for treatment for cholesterol, we can dramatically reduce the risk of both heart attack and stroke. And then finally, family history. And while family history, we can't change our genes, it can certainly make us more aware of the other risk factors that we've talked about so that we can address them more aggressively in those patients who, based on their family history, have a greater risk of heart disease.
All right. Well, I like that. That's 1, 2, 3, 4, 5. 5 good things that we can talk about. But I want to go back to when we started with the high blood pressure. So what is happening to someone when they have high blood pressure that you're saying it could be very difficult on their heart?
So what's happening is, because of the increased resistance to blood supply, because the pressure has gone up, the heart is having to work harder. If you think about when you exercise or someone goes to the gym and they're using weights, what they're trying to do is grow that muscle in response to the increased weight that they're lifting. Well, here is basically more of a workout for the heart, and you're asking the heart muscle to do more than it should. But unlike exercise where you're lifting weights, this is not a favorable response for the heart. We don't want the heart to thicken, because when the heart thickens over time, it becomes less efficient as a pump. It stiffens and it doesn't work as well. In addition, the wear and tear on the blood vessels, the ongoing work that blood vessel is seeing because of the high blood pressure puts more strain on that blood vessel, and so it's more likely to develop plaque. And what we mean by plaque is cholesterol deposition, thickening within the blood vessel itself, which then increases the risk of heart attack. So it's really two things that are happening. Something right at the level of the blood vessel, which increases the risk of a heart attack developing or of a stroke as well. And also a secondary effect that high blood pressure is putting more strain on the muscle of the heart, so the muscle is now thickening, and that is ultimately going to have an adverse effect on the individual as well.
Whoa, that's a lot. And so that should scare someone, and they have to get that blood pressure down. But now, what about losing weight? How does that help the blood pressure, which then helps the heart?
Yeah, I'm glad you brought that up. Weight itself we worry about. Now, interestingly enough, it's not what we call an independent predictor of heart disease. In and of itself, it doesn't say heart disease is a greater risk. But the reason for that is it does it by doing other things. Patients who are overweight, by and large, will have higher blood pressures, be more likely to develop diabetes, and have higher cholesterol. So it's the impact that weight has on those other three risk factors, which we talked about earlier, which increase the risk of heart disease. By losing weight and by putting less strain on the heart as a result of the weight loss, and therefore improvement in blood pressure, improvement in cholesterol, and improvement in sugar control, you dramatically reduce the risk of heart disease.
It seems so easy, Dr. Lieberman.
Easier said than done, that's for sure.
I know, but and of course, we can get to the smoking, but I want to kind of stick around this because there are so many people walking around with extra weight, and you've told them all this, I'm sure, and yet they just can't figure it out. Do you actually give them diets? What do you give them so that they can do this?
So we'll actually talk about a couple different things. I mean, first of all, unfortunately, the diet that we've become more accustomed to in this country includes more saturated fats, more processed foods, higher salt intake, everything that basically increases the risk of heart disease because of the issues we've already talked about. One of the things that I will encourage my patients to do is, number one, it needs to be a lifestyle change. So doing a fad crash diet and losing weight without lifestyle modification is going to accomplish nothing, because the patient's going to lose weight but then gain it all back. It needs to be a lifetime commitment to a healthier diet. Now, what does that consist of? It does consist of a low carbohydrate diet, avoiding the simple carbohydrates where possible. It doesn't mean you have to eliminate all carbohydrates, but keep the simple carbohydrates to a minimum. What we mean by simple are the simple sugars. And for easy descriptive purposes, if it's white, it's bad. Pasta, white rice, sugar, things like that. We want people to have more whole grains when they're going to take in carbohydrates. So that's the first issue. We also do need to limit quantities. People who go out to restaurants, if you look at the calories and the size of the portions that were generally served in this country, they're rather excessive. In general, if you cut your portion in half and ate half of it, you'd already be making a significant difference in terms of what could be done. The other thing I'd encourage people to do is to eat more meals but smaller meals. By doing that, you rev up your metabolism, and it's better handled by the body. So if we did 4 or 5 smaller meals a day rather than 2 or 3 bigger meals a day, that would improve. And hand in hand with all of this has got to be an exercise program, because unless somebody increases their physical activity and increases their metabolic rate by increasing their physical activity, diet alone is going to be difficult to achieve the goal that we want to achieve.
Oh, that's good stuff. I mean, I can see everybody walking out of your office and saying, okay, I'm going to be thinner and I'm going to be better and I can do it. But then they get home and they go back to their own habits. So
they do. And it's important, actually, when you're, again, you mentioned this much earlier on about the relationship you form with a patient. You got to have realistic goals. I don't look at a patient who may need to lose 100 pounds and say, the next time I see you, I want you 50 pounds lighter. That's not realistic. We set a realistic goal. let's try and lose 1 to 2 pounds a week for the next 8 weeks. Let me see you back in 2 months, and let's have you 8 to 10 pounds lighter in 2 months. Let's set something that's realistic. And when someone does achieve the goal, you need to compliment them and applaud what they've been able to accomplish. They're not at the ultimate goal right now, but you need to set intermediary steps that are realistically achievable.
Good advice, and yes, and it's almost like you have to be there in their home with them in some way, but you're not, of course, and you're only going to see them once a month, if that.
Unless I run into them in a restaurant, and then they all know that I'm looking at what they're eating.
Oh, I know. Well, it's very difficult, and of course, you deal with the elder population. We can't even take time to talk about the children at this point, but maybe
Right.
in another interview. But they do have some, we call it comfort food, and they've grown up with this food. So I think your advice is just, can you eat half and take it home? So many people now do have doggy bags, and they do
Right.
take half of it home, but maybe when they get home they eat it too,
Yeah.
I don't know. But as a cardiologist, I mean, you know what's good for them, and you probably plead with them. But unfortunately, not everybody can manage it. It's called motivation, and I don't know how you do that, but I'm sure that there are ways. I'm sure you tell them about going to Weight Watchers or
Yep.
going to some places that will help them.
Right, and again, like everything else in medicine, it needs to be individualized. You can't have a general recommendation that works for everyone. There are some guidelines, but different patients are going to respond better to different motivational tools and to different diets. And so you need to work it out individually with the patient and figure out something that's going to work for them. And it may involve getting their significant other on board with what's going on, because as with everything else, if you're going out with another individual, that's going to have some impact on how you eat and what you do.
True. I was just thinking about the smoking. That's probably the worst thing if someone smokes and now they're trying to quit, and then they have a partner who smokes. I mean, that's just unmerciful.
Yeah, it's got to be a joint effort. I'll tell you, one of the first things I do with patients in terms of smoking cessation, we talk about if they have a significant other, whether or not they smoke. And the second thing we talk about is where are they most likely to smoke. And many patients may not have a significant other who smokes, so they're only allowed to smoke outside on the porch. And I say to them, fine, you're not allowed on the porch for the next month. You avoid the area where you're smoking. That's it.
Oh my, that's great. Well, you really are such a wonderful person to interview, because you're so peppy and you have this great enthusiasm, and I just love that. And I know that your patients must really be very happy that you take the time to do this. Before we run out of time, and I hopefully will have you back again, but I thought I would like to know a little bit about the stress test. Is that what would require? Why would you have someone have a stress test?
Okay, that's a great question, and that could be a topic of a whole interview, to be honest. But a stress test is really indicated for trying to determine in someone who is having symptoms that you believe are related to the heart what the nature of the abnormality is. A stress test, unfortunately, is not a good predictor of future heart attack. You don't do a stress test as a screening test. You don't take a patient who has no symptoms, do a stress test, and say, aha, we have something, or no, there's nothing. Looking at the cholesterol, looking at the blood pressure, looking at the sugars are better predictors of what's going to happen in the future than a stress test. However, somebody who is having chest discomfort, which I believe is coming from their heart, the stress test helps to guide me as to how significant I think their blockages are, where they're located, and whether or not I need to do something more aggressive than simply medications, whether I need to contemplate doing an angiogram or something along those lines. So that's where a stress test is useful in terms of assessing what I call prognosis and determining how best to manage a patient.
Well, that's great. Well, Dr. Eric Lieberman, who is a cardiologist over there at Delray Medical Center, has really been giving us some motivation, and he's certainly answered in just 15 minutes so many questions that many of us have, and we want to thank you so much. You'll be able to look for Dr. Lieberman on YouTube shortly, and we thank you again.
Thank you very much for having me. I appreciate it.
All right. Bye, Dr. Lieberman.
Take care. Bye-bye.